It's something we deal with multiple times a day. It's not just in this field, it's in all kinds of things. And I can understand to some degree where it comes from. Yes, many medications, these and others, cost a lot of money. There's a concern of, is it being used appropriately? So one thing often insurers ask who need a prior authorization for a medicine, what's the diagnosis? And kind of show me the notes that shows this has really been evaluated well.
ADHD Rewired, episode 116. This is the show designed to help those of us who have really good intentions and a slightly wandering attention. My name is Eric Tivers. I'm a licensed clinical social worker, coach, and consultant. We know that starting can be the hardest part, so let's get started. But first, let me thank our sponsors. Hello, ADHD Rewired listeners and community members. I want to let you know that the ADHD Rewired Coaching and Accountability Group is starting May 23rd. And guess what? I am extending registration for a few more days. We only have a couple spots left. We have 4 spots left. And we could all use a little extra time, right? Go to coachingrewired.com. If you're not familiar with this coaching group, let me just share it with you quickly, and this was on a couple episodes ago, what it might sound like when you are done getting your ADHD rewired.
I got a place to laugh at some of my more amusing ADD tendencies.
I've been making a habit of every morning printing out a blank hourly calendar for the day and taking about 15 minutes and planning out my day. I tried to do it the night before. Like, ideally, I'd like to do it the night before, but the problem I was finding was that I was just like, my brain would be too fried at the end of the day. In the morning, like when I first get up, I feel like I can execute it that much better.
I'm an opera singer, and I got a gig in Italy for this summer that I'm really excited about because the coaching group helped me stay focused on preparing for the audition.
I have meditated and done yoga every single day for the entire 10 weeks.
I got my townhouse packed up and cleaned and have a real estate agent now, and he's hiring on people to fix it up, and that's a miracle.
I started drinking cream in my coffee every morning because of Dan.
I started saying no.
I got my email inbox to 0.
I created a place where I write down the priority of my week, and then I execute that priority first.
I got my study plan in place and going without completely killing my children and husband.
I showed up every single time except when I was on my silent retreat.
Well, I made a list of things that I'm concentrating on and a list of things I'm eliminating, and I'm working on automating and delegating some other things.
I adulted. I got up and brushed my teeth and I washed my hair. Went to class. I adulted.
I got my taxes done with 3 days to spare.
Well, you probably have less than 3 days to spare. This really is your final chance to register for this summer's coaching session. Go to coachingrewired.com and schedule your call with me. Registration truly ends at the end of this week. I'm shooting for Thursday. Join me, schedule that call, coachingrewired.com. Now, let's get ready for an amazing episode that you're going to want to share, possibly with your therapist. Welcome back to another episode of ADHD Rewired. I'm really excited for today's show. Today is going to be a little bit different, I think, of a show in that we have our guest today is Dr. David Pomeroy, and I'm going to let him introduce himself, but here's the essence of what we're going to try, the attempt of today's show. Let me back up. We know that sometimes it can be hard when you go into your doctor and you're either having to defend yourself, having to explain yourself, or feeling like your doctor just doesn't get it. This is the episode, if all goes the way we want it to go, that you will be able to hand this to your doctor and say, please listen to this. So if you are the doctor listening to this right now, your patient gave this to you. Thank you for taking the time to learn more about ADHD. I think that you will learn through the course of this episode that if you want some positive reinforcement, learn about ADHD because it's so treatable. Dr. Pomeroy, I hope that introduction was okay with you. Why don't you tell the listeners a little bit more about who you are and what you do?
Sure thing. I am a family physician, have been a family physician for 37 years. In the first 26 years, I did general family medicine, everything from delivering babies, assisting surgery, office practice, and things in general in family medicine narrowed down to just office practice. And more that was accountant driven. How many patients are you seeing? Cut down the time. You only have 15 minutes. And when the sign went up in the waiting room that said, if you have a second problem, make another appointment, I was out of there. I've never been able to practice medicine that way. And at the same time, two other things came along with that. About 3 years prior to that, I was diagnosed with ADHD. And my first question was, how do you get through med school with ADD? And the person I was talking to pointed out, that's your hyperfocus. And that's exactly the explanation. I just ate up med school. I love it. And I still do in spite of all the other things with it. And then I got talking with one of the other local physicians who primarily does ADHD work. And as we talked more and more, he said, you can figure out how to do it. There's plenty of business. I need more help. So I took the jump and started my own practice. That was in August of 2005. I've now seen over 3,000 people and, of course, see many of them on a regular basis now. I fully enjoy it. There's so much neat research and information coming out. And unfortunately, there's still a lot of myth information out there in public media. And a lot of it because people associate, ADD, that's a hyperactive 8-year-old kid. But you grow out of it by the end of high school, right? Wrong. And that gets into some of the things we'll talk about as far as why treating ADHD is preventive medicine.
Okay, so talk about treating ADHD and understanding ADHD is preventive medicine. So as you were describing in just a moment ago, that when you saw the sign in the doctor's office that said, if you have a second problem, make a second appointment, you were out of there. How does the primary care physician, who is there to screen people for all kinds of things, how do they make room in that 15-minute office visit to see if ADHD is something that may be presenting for their patient?
That's a great question, and one that I've kind of wrestled with in terms of wanting to help other docs understand how to do it. It's one thing to have an understanding of the condition, medicines. It's okay, how do I fit that in the day? And it's a segmented process, I guess, in family medicine and pediatrics as well. We're used to the fact that you don't try to do everything all at once. You get maybe some history, someone comes in, I'm concerned about it, or you pick up some things that would suggest maybe that's going on. Give the people some of the reliable screeners for ADHD, not the 6-question quick one, but some of the more in-depth ones.
Like
and
what?
Ask them, well, there's for children one that's called the Vanderbilt scale that you can actually access through the National Institute of Healthcare Quality, NICHQ.
And I'll get a link posted right on the show notes page for this episode.
Great. And that has, I think there are like 28 different things in terms of suggestions for teachers, parents, everything else. But the key ones are a parent, they call it informant. So the parent informant and a follow-up parent and a teacher informant, follow-up teacher.
Okay.
So for a child under 18, you can ask the parents to give one to the teacher and parents fill it out. And it goes through not only the ADD diagnosis things, but also things about oppositional traits, depression,
And
etc.
talk a little bit, David, if you would, about why that is so important, that piece of finding out either the teachers, the parents, or for adults, because my listenership is primarily adults, why having that other person besides the person of concern fill out these rating scales. Why is that part so important?
Sure. And there are two reasons. One, in the diagnostic criteria that all have to be met for the diagnosis, you have to show that there's an impairment. The condition causes problems in at least two kind of life situations, at school or work, at home, and social relationships. And the other relates to the nature of ADHD, in that those of us with it are not very good at observing ourselves. Mm-hmm. So someone with ADD may say, oh yeah, I do that every once in a while. And his wife says, are you kidding? Yeah, 4 times a day. Because it's just, we don't know any other way to do it. That's the way our brains are wired. And so that self-observation, and unfortunately, in a way, the rating scales are all, not at all, sometimes, often, all the time.
Right.
So someone with ADD would put sometimes, someone who knows them would put more often. So the importance is having enough of the symptoms at a high enough degree that then that meets the criteria.
Now, what about on the other end, though, where you have physicians who will do a quick screener and give an ADHD diagnosis?
Yeah, that's also a problem, because a quick screen, or just in the office, the screen looks like there are enough things, that must be it. You have to look at other possibilities that may explain the situation. And with adults, usually you can sort out whether there are other ones fairly easy. The tricky part with adults is getting a childhood history of the symptoms. It doesn't have to be the diagnosis, because that's one of the criteria, that these symptoms were present before age 12. In children, it's kind of the other way around. Obviously, the symptoms are there. Are they also from learning disorder? 50% of people with ADHD have learning disorders, dyslexia, dysgraphia, problems with writing. So that may be along with it, or it may be the entire explanation. Another one, and this can happen at any age, is concussions. So particularly multiple concussions are a really severe one. Traumatic brain injury that can cause things that essentially are ADHD. It can be diagnosed as a undifferentiated, but the treatment's going to be a little different.
Okay. So looking at the different rule outs, the things that kind of look alike, what about for the doctor, maybe a psychiatrist, who treats other disorders but looks at ADHD as a, the maybe puts air quotes around ADHD, or it's this all ADHD thing. It just gets overdiagnosed. I just think you're anxious and you're depressed.
Yeah, and unfortunately, a lot of most psychiatrists don't have specific training in ADHD. They get very little in their training programs, unless it's a child psychiatrist or someone who has the interest. And I was asked by, I think it was Rick Green at one point, what do you say to the psychiatrist or the doctor who says, well, I don't believe in ADHD? My answer was goodbye. Find someone else, because you aren't going to be able to convince that person. And unfortunately, there are docs and people, a lot of people in school systems, everything, think, oh, you're really lazy. It's just because you're not motivated. You aren't trying hard enough.
So what I want to ask you this is, so let's say the hope is that this is the episode that a patient will give to their doctor, and the hope is that this doctor said, you know what, fine, I'll listen to this episode. I'll listen to this audio. And what do you tell to that doctor? So if you had this opportunity to speak directly to that doctor who is in the camp of, I don't really believe in ADHD,
Mhm.
Talk directly to them right now.
Okay. Number one, it's not a question of faith. It is scientific method. I assume you believe in the scientific method. Okay. 1999, functional MRI showed there is a different structure in the brain of people who had all these symptoms we call ADHD. And that has progressed now where we can map neural networks. They're different in people who have all the symptoms of ADHD compared to not different. There's good basic science research done at the National Institutes of Health, so no one paid extra for it or whatever, showing the dopamine transport system is different. Also, the genetics of the dopamine transport system, there are 4 genes that are abnormal. That is different than neurotypical folks with ADHD. So there's a lot of good, solid scientific evidence that this is real. People say, show me the pictures. Okay, they're there. With good, reliable research, not something started by a pharmaceutical company or whatever.
Okay, so what about then the doctor that says, I just don't have time to really learn enough about this, and I don't want to get sued for prescribing stimulants for someone who's a drug seeker?
Sure. I think the learning opportunities, there's one organization you can look at their materials. It's the only one. It's up in Canada called CADRA, CADDRA, Canadian ADD Resource Alliance. You don't have to be a member to access much of their educational things. And this is an organization for professionals, so you can get good information. There's no such organization in the U.S. for adult ADHD. There are plenty for children. So that's one resource. And there's everything from webinars and podcasts and as well as in print books. I would say a conference is often the best place where you can hear speakers, ask questions. There's more interaction. But you do have to seek it out and look for it.
Okay, so what about the doctor that he's willing to try to do some prescribing, but just doesn't really feel comfortable enough with it, so maybe will only prescribe a very low dose?
Mm-hmm. And this is part of the education of doctors, and rightfully so. Many docs, I think most of us, are concerned about drug seekers. One thing I saw recently looking at what's the percentage of the medication being abused of different classes of medicines. With opiates, it was something like 25%. With amphetamines, it was 2%. So it's really pretty low. The bigger concern is college students, because 30% of kids who've taken Adderall within the previous 6 months did not have a prescription. They bought it or stole it. They're using it as a study drug, not as a party drug. So that's another whole issue. So it is something to be concerned about, the diversion risk, but there are ways to look at that. But the dosing, the key is it takes enough. So looking in a book and saying, well, we start at 20 milligrams of Adderall, for instance. Well, maybe that person needs 10. They're going to get a heck of a bunch of side effects. Or they really need 30. And to say, well, 20 didn't work, you probably don't have ADD, that's wrong. So you start low to make sure, minimize any potential side effects, and you work up little by little until it works. Most people, it's going to be within kind of the FDA guidelines. Some of them, it's going to be more than that.
And so there are times when prescribing higher doses than the FDA guidelines is appropriate.
Right. And there are, for instance, with Concerta, the guidelines go up to 72 milligrams, which actually just means the company only went up to 72 milligrams in the initial testing because they didn't want to get more side effects by going up higher. But there's been some post-release studies showing 81, even up to 90 milligrams in a day is safe, effective, and reasonable. There aren't those studies for every med, so sometimes there are other ways around it. But some people, Vyvanse, 100 milligrams, that's what works.
And the FDA approval is at 70 for Vyvanse?
Yes. Now, the key, of course, is a good screening to make sure someone doesn't have heart disease or a history of sudden cardiac death in the family, and keeping track of is someone filling only your prescriptions? Are they getting it from someone else? I have a stimulant contract that I ask people to sign, very similar to the opiate contracts now that most docs use, that says, I have the right to ask you for a random urine sample to check what's there.
Okay.
So if I do that and there's no amphetamines in there and they've supposedly been taking Adderall, it's going somewhere else.
Right.
Or they also have 2 other drugs they didn't tell me about. So monitoring is one. And yeah, if there's side effects as you go up, you stop that one, switch to another drug. And that's the primary thing. If something in amphetamine class doesn't work, then you want to try something in the Ritalin class, for instance, and vice versa.
Okay. So whether you started in the methylphenidate or the amphetamine, it doesn't really matter where you start?
Basically. And there are a couple of things. If someone has a lot of anxiety along with their ADD, I probably wouldn't start one of the amphetamine ones because in general, they tend to put people a little bit more on edge.
Okay.
So I don't want to trigger something that may feel like anxiety. Or if someone has a lot of anger issues, which gets into some of the ADD emotional regulation things, then I'd also start with a methylphenidate. Doesn't mean you can't use an amphetamine, but that wouldn't be my first choice.
Okay. And then if you don't get a good, you start low, you titrate up on an amphetamine, you don't get a good response from it. You switch then to a methylphenidate. You titrate up, you don't get a good response from it. Then what?
Either pick, and there are subtle differences among each of those. So, for instance, all of the methylphenidates except one called Focalin or dexmethylphenidate are the same basic med. The Focalin dexmethylphenidate is chemically only half of the regular methylphenidate combination, and sometimes it's more effective because it leaves out the second part of methylphenidate that may just add to side effects but not necessarily help. The other thing is the amphetamines, the long-acting ones, Vyvanse, Adderall XR, new one called Avikio, are all different balances of types of amphetamine. So someone may get really, really irritable when they're taking Adderall, but they take Vyvanse and they're fine because they're different subsets in there.
Okay. And what about the non-stimulant medications?
Well, there are 2. One of them, called guanfacine, Intuniv was a brand name of it. That one is more useful as an adjunct to add on to the stimulant, partly because the main side effect is it makes you sleepy. And it takes a lot to get to the help the focus aspect. It can help some of that oppositional, frustration intolerance things. So it's not usually a primary one. The other is one called Strattera that came out about 2004 or 5. And it seems to be effective for about half the people who take it. If someone has a lot of anxiety also, it's effective in about 70% of those folks. The difference is it's one you have to take every day. It has to build up a blood level, and it still may take 4 to 6 to 8 weeks to see how well it's working. I find about a quarter of people take it have side effects, either nausea or they're just emotionally don't feel good. So that one's out. But another quarter of them take it 2 months, titrate up a little bit higher, and nothing happens. So it costs more time, and yet it's still a good option if the stimulants cause too many side effects, for instance.
Okay. And what about for the patient that comes in who maybe has gone through the screening, clearly has ADHD, but there maybe is a history of drug abuse?
And that's, there are a couple of different things. Certainly if it's recent, then one addictionologist, psychiatrist who also treats folks with ADD says, I'll give you Wellbutrin, which is an antidepressant, has a little bit of a stimulant effect, or Strattera, until you can show me that you were at least 3 months clean and sober, you're in a 12-step recovery program, you're seeing a therapist, and your UAs are always clear, and I'm going to do one a number of times a year. And once that's put in place, I only use Concerta or Vyvanse for those folks. You essentially can't abuse them. Concerta is a slow release. You can't make it release faster. You can grind it up and you get a bunch of plastic pieces. Vyvanse is what's called a prodrug. So the actual Vyvanse itself, once it's absorbed and in the bloodstream, an enzyme in the bloodstream breaks it into the active part. You can't speed that up. So that's still going to be a slow, gradual process. So yes, if you probably took 150 milligrams at once, you might get a little rush, but it's not going to be the blast that someone is with addicted. The other thing is, if someone had an opiate addiction, probably a stimulant is not going to trigger that same craving for the opiates. Mm-hmm. It's somebody who's had a cocaine addiction. That's a lot trickier. Okay. And I go over with them, you may get some of that rush effect that could trigger some of your cravings. That's why they need to be in a good recovery program and have some time clean and sober. But
what about when, because I know this sort of gets into some of the nuances to prescribing, that some of the research has shown that you actually may decrease the tendency towards those kind of impulsive relapse type of behaviors if you're given that stimulant medication.
Exactly. And there are a number of good research reports, again, not supported by pharmaceutical companies, that show there is less risk of relapse for substance abusers who also have ADD than those who haven't, their ADD isn't treated, partly with that impulsivity. They're self-medicating, trying to get away from the anxiety, the constant negative feedback about their behaviors, and they get some success with treating the ADHD. They don't need that self-medication part as well. So there is very good evidence that it's possible carefully to work with that. Now, the FDA indications say it's contraindicated with history of substance abuse. And certainly at first that had to be put in there. But now that there's experience and good evidence that it's okay in a careful, controlled setting, it's reasonable to do.
So what about the doctor who's thinking, all right, I have so many patients that are asking me about ADHD. I'm just not comfortable prescribing, but I want to maybe begin somewhere. And I know you mentioned some of their other resources. And so let's say they look at these resources, they sort of get a feel for kind of prescribing approaches. Where do you start? How do you titrate? What should they look for then to see, is the therapeutic effect doing what we want it to do? And so is it robust enough? And how do I know when to, as a doctor, how would I know when to stop titrating up?
Good questions. In terms of the first, and this relates to sometimes people with ADD aren't good observers, they may not see how much difference it makes. Most people can. But I suggest to people pick 2 or 3 things that are most bothersome for you. Losing track of in the middle of a conversation, or having to reread something 3 different times, having to be told 4 times, reminded to do it before you actually do it. And even keep track 2 or 3 times a week. Boy, haven't missed any conversations. I'm not daydreaming. People who are married, your spouse is going to tell you that pretty quickly. Hey, you stuck with me this whole 10 minutes. So those are, one thing is to look at what are the symptoms. Can you see if they're improved? Things like organizing, figuring out what to do first, prioritizing, cleaning up the mess on your desk. Medicine probably isn't going to fix that. It can help you stick with some of the strategies, but you have to learn the strategies. Right. But as far as that first effectiveness, people will find they start something and they can stick with it without thinking of 3 other things, and they go start all 3 of those and nothing gets done. So that's one thing. The other kind of tricky part, of course, is there's no way to measure what's the best response. If someone has high blood pressure, okay, their blood pressure comes in a good range. You don't need to add more medicine. So I have people take enough so that they are sure it's working. And I say, take it for a month. So you know all the different situations it's going to help. Take it every day, weekdays, weekends, and then go up 1 notch and see if it's different. Because someone may get 65% improvement from where they had been. That's a big jump. Mm-hmm. They take a little bit more, and now it's 85. Or they take a little bit more, and it's 70 instead of 65. Stick with the lower dose. So again, it comes down to that, try it out. People have to really experience and know what that first level did before they look at going up.
There was I think it was 2 years ago at one of the CHAD conference, and I was sitting in a session, and I'm trying to remember who it was that was talking about this. I think it was like the Texas algorithm for prescribing. And one of the things that they talked about is that you start low, you titrate up until you hit a ceiling where you're starting to get side effect, and then you come back down a notch, and that's where your dose is. Yeah,
I don't agree with that one.
Okay.
It's just never made sense with a number of things. Go up until you feel lousy, and then take a little bit less. You shouldn't have to get to the feeling lousy part.
Mm-hmm.
So
it sounds like there is some variability, though, in the way people prescribe.
Right. There is. And what I tell patients, as soon as we start talking about medication, I'll say every other question you ask me, the answer is going to be, it depends. It depends on your metabolism. Mm-hmm. It depends on the context. It depends whether you respond to this medicine. So there is a try it and see what works. People call it trial and error. I'd like to think it's more trial, and if it works, great. And if it doesn't, we just try a different method. It's not necessarily an error. It's just
that doesn't flow off the tongue as well, though.
Well, that's true. That's true. There is the plan, do, study, act cycle, or something like that, where you look at the situation. If we change this, is it going to help? You change it. If it doesn't help, toss that one out, go to the next. And it's that kind of approach.
So what are the things that you think that, besides from the medication, when a doctor is looking at ADHD, besides, I think that so often if a doctor is just looking at the DSM kind of checklist, right, there's so much that is missed in there. Because still to this day, it's described behaviorally, but it's not a behavior disorder. So what are the things that are important for a doctor to understand about this disorder of ADHD, where you have, where hyperactivity doesn't even have to be present?
Right. And that's certainly one of those myth kinds of things that, you're not hyperactive, you don't have ADD. Well, almost half the people with ADD don't have the hyperactive part. They have the daydreaming, forget things, procrastination, not listening, and they kind of fly under the radar for a while. So the things that have been one of the main aspects of ADD that have been left out of that diagnostic things probably since about the early 1990s is the emotional aspects. And I think they came up with, okay, oppositional defiant disorder, which basically is a lot of the emotional stuff with ADD. I don't think I've ever seen oppositional defiant without ADD.
It's usually conduct disorder.
It's just a dimension of it. So that emotional regulation is what isn't working. That ability to inhibit a response, whether it's emotional or just impulsive, that's what's not working. And the issue with folks with ADD is that not only is it not working, but the registering that it didn't work before isn't working. So kids that do the same thing 5 days later or 10 minutes later, that's not now. I mean, now is here. The other time was not now. So it's off the radar, which is obviously very frustrating for parents, teachers. I can remember my father saying many, many times, how many times do I have to tell you?
My mother would tell me ask me the very same thing. How hard is it to close a cabinet? I've told you 1,000 times. How many more times do I need to tell you? I said, probably at least 1,000 more. And, you know,
yes,
I wasn't trying to be a smartass. I was just being honest.
I definitely would not say that to my father, the kind of reaction I'd get. But I'm thinking, well, obviously it's got to be more. I didn't know, asking, why can't you do that? Asking an adult or certainly a child why you couldn't, that's not going to work because they can't explain it.
Right. You know, and I think it's a shaming question.
Oh, yes. Yes. It implies you're not doing it right. And people with ADD, we don't know why. This is the only brain we know how it works. So we don't know why ours doesn't work the way neurotypical brains work. So the answer to why is why not?
I was talking earlier this morning to a potential client, and she was sharing with me her frustration that she just went to see this new psychologist to get some help with her ADHD, and the psychologist said to her, "Well, have you thought of just writing a list and using a calendar? That will help. That'll help." And she and she shared with me that the psychologist didn't even understand why that suggestion was so frustrating to her. So for the doctor, psychologist, therapist who's listening to this now, who, with good intentions thinks that, keeping a list in a calendar is a great idea, for the person who has ADHD, what does that person hear?
I'm sure they've probably tried the list. And the way an ADD mind works, it's often associational. And you think, okay, packing for vacation. Well, I'm going to need this. And you end up with this list of 25 things that are not in order. They aren't related. So trying to pick that out is frustrating. Now, there is a way, a strategy to do that, termed a focus map. And you can do it with mind mapping on a computer, but you can also take a piece of paper, put one central box, that's your vacation. And you get 4 boxes around it. Where are we going? How are we going to get there? What kinds of things are we going to do there? And then you put lines from each of those and list what it is. Well, if one box gets so full, there are too many lines, that becomes its own center box. But now you've got this grouping of associated things, a whole lot easier to sort through. What do you do first? You don't figure out what you're going to do until you know where you're going. So that's one of the kinds of strategies that can help someone with ADD. You're still making the list, but in a format easier to see. Same way with a calendar, it depends on the formatting.
And the person.
And the person. One kid showed me his planner from school, and it had so many colors and circles and little sayings in this. I couldn't figure out where you're supposed to write something down, much less find it later. And some people, the days of the week on one side and a big blank page on the other, or a full calendar thing. There are a lot of different systems. There's certainly a lot of different apps that can help. One may not work for someone and it works for the others.
And I know that one of the things that you've been also working on is app development. What I want to do really quickly is take a quick break. When we come back, I'd like to talk a little bit about some of your app development, some of the other things that you have going on right now, as well as, because I want the doctors who are listening to this to kind of stay tuned to this, how to deal with insurance companies who are denying.
Oh, boy.
We're about to get Dr. Pomeroy fired up. Before we do, we will be right back. This is the last time you're going to hear me say that you can register for this summer's ADHD reWired coaching and accountability group. Yes, registration was scheduled to end on Friday, this last Friday. I'm in charge of registration, and I'm giving you an extension. We have 4 spots left. Go to coachingrewired.com and schedule a call with me right away. My schedule is set up so we can be talking in the next 15 minutes. Go to coachingrewired.com. Session starts Monday, May 23rd. I hope that you will be a part of this group. Go to coachingrewired.com. If you are brand new to the podcast and to ADHD Rewired, go to that site and listen to some of the past episodes that we've had guests from the podcast on, including in some of these, the mid-rolls that you're hearing right now, people talking about their experiences of the group. This truly can be life-changing if you are looking to jumpstart your summer productivity. The best way that you can do that is to go to coachingrewired.com and schedule your free 20-minute consultation with me. We have 4 spots left, and I hope you will be one of them. And we are back with Dr. David Pomeroy. We are talking today about, as I mentioned, that this is the more unusual episode. The focus really is give this episode to your doctor. So hopefully you maybe you're a doctor who is driving home or at the gym, and one of your patients or clients said, please listen to this, and you are doing so. So if you are, thank you so much. Your clients, thank you. And I really hope and believe that the information that you are getting today is going to do wonders to delivering better outcomes for your clients and patients.
And I certainly would say that some of the most appreciative patients you have will be ones that you've helped turn their life around. People that thought they couldn't do anything, all of a sudden they're getting things done. Their boss notices that they're performing better. One person said, yeah, I've had 3 promotions in the past 4 years. I spent 6 years there and I never got past a certain level. And he attributed to the fact that he could get things done. He learned how to organize and plan, but he knew this is what I need to do today, stuck with it, and got it done.
For me too, I mean, just really quickly, when I was diagnosed with ADHD, I nearly failed out of college. And that's when I got an evaluation. And I made the dean's list every semester from getting on medication. And it was like to understand how it felt for me. So I was someone who had inattentive ADHD. It was like I had this fog that was in my brain my entire life. And because it's all I ever knew, I didn't know any different. And so that I remember that first day on medication feeling normal for the very first time in my entire life. And so, I just want you to know, if you're a doctor listening to this, that is an experience that you can give to your patients. And I mean, with a lot of these other medications that we're using to help patients with other conditions, it can take a lot of work. And, it's kind of nice sometimes to have a little bit of immediate gratification when it comes to prescribing.
Yes. And that is one notable fact docs need to know, and patients as well, is that the stimulant medications, you will see that day the effect of whatever you took that morning. So if you really need a medium dose of something and you're taking a low dose, you could take it for a month. It's not going to make a difference. The first day you take that medium dose, whoa, this is a different ballgame, which is part of what helps in See, you're having side effects, stop. Don't take it anymore. They're only going to last that day. Don't take them anymore. We'll switch to something else. But you also see the benefit very quickly.
So let's talk about one of the, I think, probably the most frustrating aspects of any healthcare provider, insurance companies.
Yes.
I think your face has shifted a whole hue of red.
Yes, and my blood pressure just went up 10 points. It's something we deal with multiple times a day. It's not just in this field, it's in all kinds of things. And I can understand to some degree where it comes from. Yes, many medications, these and others, cost a lot of money. There's a concern of, is it being used appropriately? So one thing often insurers ask who need a prior authorization for a medicine, what's the diagnosis? And kind of show me the notes that shows this has really been evaluated well. Mm-hmm. But then it gets into one rationale as well. Long-acting medications are simply a convenience for adult patients. So you can only have short-acting ones after age 18.
And so this is something you have actually heard an insurance company come back.
It's written. That's what was the denial. And then I asked, okay, what's your criteria for making this? They sent them back, and one was an article in the year 2000, which was before, in a professional journal, before any long-acting ones were even available. Another one was in 2004, when there were about 3 of them and very limited experience. And that was it. There was no other real clinical rationale. So the thing that's missing oftentimes is a clinical rationale for why to do it. No, you can only have these, you have to try these 3 short-acting medicines for at least a month to prove they don't work. Well, if someone's throwing up taking Ritalin after 3 days, I'm certainly not going to ask them to do it for a month. Mm-hmm. So there are all kinds of hoops to jump through, and it is difficult. And for a busy doc in regular practice, you end up saying, well, we can't do it. I get so fired up, I'm ready to take them on.
So what are some of the things that have worked for you?
One is to ask for what their criteria are and send them information of up-to-date clinical information. So that's one thing. The other is to point out, and this is where you have to document it in the chart, yes, they've tried this one, they had vomiting, this one, they got really depressed. That's why this one is necessary. The difficulty on that, sometimes an adult will come to me and they've taken medicines back when they were in junior high school, and they didn't for a while. Now they want to start them again. They don't remember what they took back then. I don't. Though if it was before 2000, it was basically Ritalin or a methylphenidate. But after that, it gets tough to track it down. So that's showing what didn't work in the past. Mm-hmm. The clinical rationale part, once your blood pressure comes down, it can be tougher. There's a European consensus statement on treatment of ADHD in adults from 2011, mm-hmm. and the Canadian ADD Resource Alliance has excellent background on that. And has to get through their whole national health program. So it's pretty well studied and vetted as far as why one thing or another should be chosen.
Okay, and then dealing with like the dosages, or they won't approve the name brand versus the generic. What are some of the strategies that have been helpful for you in getting approval of those things?
In terms of dosages, pointing out, well, for Concerta, now the generic methylphenidate ER with 18, 36, 54 milligram doses, that there are articles that show higher doses are safe, effective, improvement in blinded trials and those kinds of things. Some of the others, it amounts to some kind of side slip. I don't want to give away entirely why it works, but if someone 80 milligrams of Vyvanse really works, the only way to get there is to take 2 40s. No, you can only have one a day. Well, if you got a 50 and a 30, it happens to go through the insurance company's system as you're getting 150. They don't tie it to the 130 you're also getting. So that's a maneuver, I guess. And sometimes people have to say, okay, 70 is at least workable. It helps. And maybe supplement it with a short acting one. So there are some ways around it, but it takes some creative route finding.
It's just so insane. You know, it's
yes. Yes. And finally, some of the professional organizations are looking at how can we deal with this. And the American Academy of Family Physicians, and in my state, Washington Academy of Family Physicians, are specifically trying to tackle this, saying, you know, let's at least get a uniform form to deal with it, and someone who has clinical experience reviewing this and keeping it up to date, and not, not to slam some of the professionals they have reviewing it, but they aren't people who've practiced medicine in an office setting and really understand how things work, much less may not know much about ADD.
So what about then for the patient client kind of self-advocate, the one who's like, all right, I want to help make my doctor's job as easy as possible with this stuff, understanding that these are some of the hoops we got to kind of jump through. How can the patient help their doctor if there is this need for the prior authorization or whatever documentation is needed to get the medications approved?
One of the things that could really help is if the patient looks at the formulary for their specific policy. So many times in the prior auth things I get from a company will say, well, it's listed on our formulary. Great, but it may be listed and it may be different formularies for different shades of policies. So if a patient can go in, look in the formulary and say, these are the approved ones, these are the ones that says PA, prior authorization needed, then I can sort out, we could try one of these others. And if it doesn't work, then we've got grounds to say these two didn't work. Let's ask for the prior authorization. So knowing which medicines are options, which isn't always told to me, it's, well, look on the formulary. Well, I don't know how to get to it, and sometimes you can't get to it unless you're a patient or whatever. So patients could help by telling me this is what's on the formulary, and I've tried this and this.
Okay. What about the patient who new year, new enrollment period comes around, and now they have a new plan, and you guys have worked really hard together, and you got the right dosing, and the patient's doing beautifully on this medication at this dosing, and then the insurance company says, "Oh, we're not going to be Adderall XR is not on your formulary this year." What do you think?
That, I think, is the biggest frustration for me and patients. It is, I think, next to impossible for anyone, ADD or not, to sort through what are the implications for choosing this insurance to that one in terms of the formulary, in terms of the prior authorization, everything like that. Sometimes I can point out, this person tried some other things. They've been stable, no side effects, no problems for 6 years on this medication. And I've started saying, this is life affecting to ask someone to go back and try 3 times a day Adderall tablets when Vyvanse works great. You're asking them to have more risk of car accidents, put their job at risk, put their relationships at risk. In one case, I said, okay, number one, either you ride the Metro bus of the person who has to take extra Adderall, or you're responsible for the legal problems that get into when she gets into an accident. because she wasn't able to take that third Adderall XR. That this, in impressing on people, it really makes a difference in people's life function in a very serious way.
And what you're describing is not exaggeration. This is the science.
No.
This is the research. What we know the impairments, the life impairments of untreated ADHD can be.
There's one study that I believe is 33 years and ongoing, starting following people with ADD when they were 8 and 9 years old. And it wasn't something to say, well, you have to do this and you can't do that. It was just, we're going to check in every 4 years, see how your life's going. If you started taking medicine and you decide to stop, or you never took it, or you're still taking medicine, people taking medicine through high school are more likely to graduate from high school, less likely to get into car accidents, drug abuse. We're more likely to get through college, have successful jobs, higher paying jobs, fewer problem relationships. Those who didn't take medicine got into more problems. And at some estimates, 60 to 70% of people who are incarcerated have ADD. That's a big risk factor. So I think the impact of ADD is not known to most people who don't have it. And it doesn't percolate around to those kinds of decisions. Gee, they should just try a short-acting one. So it is very frustrating to have someone shift, and some companies are just adamant, nope, we don't cover Vyvanse, that's all, until you jump through all these hoops. Or it doesn't matter how many hoops, we don't cover it.
I know for myself, there was a year where my insurance company would not cover my Adderall. And I, as a business owner, I know that, my wife stays at home, so my family is dependent on my livelihood. I was paying $550 a month for my Adderall. And people have asked, how do you afford that? And my answer is, I can't afford not to do it, because the wheels on this bus would fall off if without it. I will get stuck in neutral. I mean, to me, it's not an option. It would be like walking out of the house without my glasses on. I would walk into a wall like pretty quickly because my eyes are really bad, and it doesn't give me an advantage. It allows me to do the things that, other people, I made this, graphic a while back. It was sort of a humorous thing. I said, thank you, Adderall, for allowing me to do the things that other people make look easy.
Exactly. And certainly anybody who kind of can't see that ADD is something real and they happen to wear glasses, I would say, take your glasses off. Okay, read that sign. Well, what's the matter? You got to try harder. Are you lazy? You're not motivated? It really demonstrates this is a biological issue. You need glasses. You can't see the glasses that people with ADD need, but they need them just as much.
And I want to make the point, too, of how shaming those kinds of words are. Because, David, as you were even saying that to make the point, I was getting a physiological feeling of being uncomfortable just hearing those words, because we hear them our entire lives. And so it's the one thing we want to be able to do is go to our doctors and feel understood, and for them to be able to help us, not make us feel like there's something wrong with us or that we just got to try harder. What we need is understanding. Patient education, physician education. When we understand the nature of what is going on, we do better.
I agree. And I think this, to me, gets down to one of the absolute fundamental things in medicine and practicing medicine. You start where the person is. I start where my patient is. I don't start with, well, this is what I read in a book, so we've got to fit you into that box. This person's having problems, things aren't working. Let's try to figure it out without labeling it, oh, you're depressed. Now, sure, many people with ADD may show up and they're depressed, but not primarily intrinsic depression. It's because of their ADHD. And that gets back around to the difficulty of trying to figure this out in 12 minutes. So even if things don't add up to the typical major depression picture. Okay, what else could be going on? One of the most helpful things I learned in medical school was, I think, in the third day when we had a lecture from one of the senior professors just about the nature of medical practice. And he quoted a doctor from the 1800s who said, "Disease tells its secrets in casual parentheses." So it's the little comments that someone makes that will trigger, wait a minute, maybe it's such and such. But if I have 10 minutes, there isn't time for me to listen well enough to pick that up. And that's the key.
That's awesome. For when I'm evaluating clients too, the side comments often tell me way more than any rating scale does. Yes. And that's, to me, the little things that someone, if I ask directly, was this a problem when you were a kid? And well, not too much. I breezed through elementary school. Yeah, because your IQ is 130. Elementary school is a breeze. And so, I didn't do homework, but I always did well on the tests. Yeah, 30 years ago, that flew. Now it doesn't. You get a C because you didn't turn in your homework. Mm-hmm. Doesn't matter. You got a 97 on all the tests. So the little remarks of, yes, and my mom was always after me. She had to remind me 3 times. They had to buy new winter jackets for me, at least 2 or 3 a winter, because I'd lose them. Those are the kinds of things that doesn't matter whether he put losing things as sometimes or often, that shows, yep, it was a lot more than most kids. Mm-hmm. And that brings the other thing about the ADD diagnosis. It's the symptoms are ones that are out of proportion to other people in that same developmental stage. Yeah, that's an important point too, because it also goes to the notion of how do we diagnose adults. You don't need as many of the symptoms. You need 5 out of 9 mm-hmm. of the either subtype or presentation to meet the criteria, because it is a developmental disorder.
And the other thing is adults, if they're doing reasonably well, they've come up with coping strategies. Mm-hmm. And people say, yes, I always write it down. Someone talks to me in the hall about something, I'll say, you know what? If you can put that in an email for me, that will help a lot. Assuming the person with ADD also has an organization system so they know how to find the email a week later.
I know that I said that to somebody just about an hour and a half ago. I was having a phone call with someone and said, would you mind shooting that to me in an email?
Mm-hmm. Exactly. So some of those strategies can compensate for the fact that you'd forget things easily. And there's a wonderful, and there are so many new technology things that can help. I just learned of one the other day called Tile.
Okay, yeah.
And it's a little plastic square, all of, 1.5 inches on each side. If you put one on your keys and the other part of it's in your phone, you can find your keys from your phone. You can also find your phone from your keys. And you can put it on your purse. You can put it on all kinds of things.
Your kids.
Your kids, your luggage. So that's the kind of thing that's a strategy. Mm-hmm. And it works. And the other one is always have the same place that you put your keys. Mm-hmm. And I tell folks sure, you're not going to stop and put them there when you got your arms full of groceries. As soon as you realize my keys are here, don't do anything else. Take them back to where they're supposed to be.
Yeah. Yeah.
Never say I'll get to it, because it probably won't happen.
And this podcast is all about sharing the stories that the science describes, right? So, certainly if you're a physician, doctor, therapist, and you've listened all the way through, first of all, thank you, because I know your time is valuable.
Sure, glad to.
And, looking at the stories, understanding this, Dr. Pomeroy and I, we shared a few stories, glimpses of stories. There's so much more, and that's But I think when we understand the nature of ADHD, we can do so much better to improve the lives of people with ADHD. Now, one of my kind of favorite quotes, and I have this hanging in my kitchen, kind of gives an understanding of what it's really like, even when you're functioning very highly with ADHD. And it's this: masquerading as normal day after day is exhausting.
Yes. The mental energy it takes to hold it together is very difficult.
So I know that you and I both had some other things that we were hoping to talk about, but I want to respect your time and the listeners' time. Is there time to talk about the app, or do we want to get you back on the show another time?
I'll say what I'm working on so far, what my idea is, and hopefully at a later show I'd be able to tell people how to find it. What strikes me is that I'll ask people at a visit every 3 months, how's your sleep been, your exercise, how's your mood, what symptoms or problems. If you have ADD, you're basing that on maybe 2 or 3 weeks at best. So if there a way you could twice a week, hopefully, open up an app, no text entry, only tap things as to these are the symptoms I still have, exercise 2 days a week, sleep only 6 hours and I'm restless. And then as you go along and collect those data points, you get a graph that shows what's going on. And then that person can share that data with me. I have the same app, and says, Dr. Pomeroy can share my data. When that person comes in for the visit, I've got 3 months that I can see in a pattern and point out, your sleep isn't doing so well all of a sudden, but 2 weeks before that, your exercise tapered off and you aren't getting any. And hopefully people on their own will see, wonder why I'm not exercising anymore. So I think that's going to be helpful for patients to see the trends, but most helpful for a doc to be able to say, this really isn't working as well as it should, or what else happened here. Mm-hmm. So that's the basic nature of it. And stay tuned. Hopefully we'll keep on working it through the development phase.
Now that you threw it out there, that's out in the ether.
Mm-hmm. And if there's anybody who wants to put some investment money in it, that's great, because that's the main thing left.
And how can people get a hold of you if they have any other questions or they want to invest in your app or anything else that they want to connect with you on? What's the best way that they can reach you?
Well, I'm a little reluctant to say send me an email, because I probably won't be able to respond to it from just the volume of things I already have to do. I also couldn't give any specific advice about a specific situation because I've not seen that person and done a good medical workup. Mm-hmm. But certainly people are welcome to look at my website, which is www.addcenterofbellevue, which is all one word. And I've got information there. I've got a Facebook page. Admittedly, I don't update it as much as I should. But I've got lists of references, some questions about things, and answers to various questions. But I'd refer also people to a good comprehensive one as far as adult ADD, and that's totallyADD.com, mm-hmm. which is run by my friend Rick Green. He would say, I'm on it. My wife runs it. Smart man with ADD, whose wife does not have it. But that's an excellent resource on all kinds of things about ADD. Another one for women with ADD, because women and girls experience ADHD differently than mm-hmm. men and boys do. And that is all caps ADD, Vance, V-A-N-C-E, advance.com, which is run by Kathleen Nadeau, who was one of the first experts in ADD to say, hey, let's look at it from the women's perspective.
I got to get her on.
Yeah, she's just a wealth of experience.
And what about you're doing some podcasting too, right?
Yes, I am. I've been doing podcasts since mid-February. The show is ADHD Focus, and it is on webtalkradio.net, not .com, .net. Of course, it's available 24/7, and my format is much like yours, to interview experts in all kinds of different fields relating to ADHD, and come up with some practical strategies or education about one aspect of ADD or another.
Well, Dr. Pomeroy, thank you so much for your time and for sharing everything that you did. This was a little bit of a different kind of episode, and I hope that listeners found value in this. Share it with your doctors and your physicians and therapists, because the more that we understand about ADHD, the easier of a time we will all have in getting our ADHD rewired. Thank you so much.
Absolutely. Glad to be here.
Thank you for listening to another episode of ADHD Rewired. And if you're new to the show, welcome to ADHD Rewired. We are more than just a podcast. We are a community focused on learning, growing, and connection. You could see a full outline of this and all other episodes with all the links and other resources mentioned during this interview at ADHDrewired.com. Help support this podcast by checking out my sponsors. I use Zoom video conferencing nearly every day, and so can you. Go free or go pro. But please go to erictivers.com/Zoom so they know that I sent you. And you can get a free audiobook from Audible at erictivers.com/Audible. And next time you shop Amazon, use the Amazon search portal at ADHDrewired.com. A small percentage of your purchase will go to support this show, and it doesn't cost you anything extra. You can also support this podcast by leaving an honest rating and review in iTunes or Stitcher. This really helps other people find this show. And don't forget to hit subscribe so you never miss an episode. Don't just be a passive listener, be an active member of the ADHD Rewired community. We are on Facebook. You can like our page, but please submit your request to join our free and growing community. And don't forget to check your other inbox, because I screen everybody before they come into our community.
I am really grateful.
I'm grateful for
Tom Nardone.